ceramic PFM. And I don't know if you can hear the sound. Anyway, this is well integrated and there's some time that already these implants have been done. These are the 3 Leone implants and the PFM done. Gum, everything looking very nice and healthy. And this is the situation that we are going to treat for him. Look, the recession in the bone, and this is tooth number 4. And most times the metal foramen is located apical to tooth number 5. We will take a trapezoidal or a divergent and plan an implantology. At the time of the surgery is much better, more accurate. Of course you have more accurate measures of methods of measuring the bone height. You are aware of that. You can take CT scans. I did not do any CT scan for this patient. So Dr. Shah, can you see you had a question. The concave of the periosteal elevator should face the bone. So that when you're retracting the flap, you are in very, very close contact. Oh my God. Look this. The mental nerve is 3 millimeter away from, 3 to 4 millimeter away from the crest of the ridge. What implant can you use in this case? Okay. Now, exactly where the tip of my instrument is, the periosteal elevator is, that is the mental foramen. We have got only 3 millimeter bone. It means what? It means that I have to make an osteotomy just 1 millimeter to 1.5 millimeter below. Okay? The crest of the ridge. So I'm going to first make my vertical. Now, if you notice I do this, I'm able to directly look if I'm getting into the canal or anything of that sort. Because if I started from the buccal aspect only, it would be a very blind technique for me. Good. So, only width of the bone is there. In this situation, what is best is to use at least a 10 millimeter diameter BOI implant. Okay, fine. The vertical cut is suction के मगर विजन में नहीं आना पड़ता है Good. So the osteotomy is progressing. So the 7 millimeter cut has been performed. The disc has gone inserted inside, but I still have to continue going, okay, further in, because we have to go all the way 12 millimeter. Okay. So let me cut some more. Okay, now I will choose a 9 millimeter cutter. Yes, it is. Now uncut and make sure that the vertical and the horizontal cut is exactly the way you want it to be. Yes, hello, Duda. Here, one minute. The rounded portion, see, the rounded portion of the implants will go on the lingual side, the flat portion is always on the buccal side. So that's, please give them a good view of this, so they can see it. Hello, are you able to see?
Yeah, perfect.
Very good. Now I will take that instrument, which is known as the K&O. It's just like a small chisel, and I will use the mallet to beat the implant inside. And my disc is only about 1.5 millimeter below the crest of the ridge. That is enough, trust me. That means you can do an implant in 1.5 millimeter. See the insertion of the implant. Always knock at the vertical post, at the base of the vertical post. Wow, very, very rigid fixation. The distal side, mesial side of the, can you see? Can you see?
Yeah.
Okay.
Mesial is black, distal is slightly yellow.
Very nice. That means, Ali, you're doing a good job, Ali. Thank you very much. So,
He's the boss.
he is the boss. He's a wonderful guy. Believe me. So the mesial side of the implant is absolutely flush. The distal is not flush. I am going to try to beat the plate distal. And then, see, again in the mandible, I told you, it's a 9 millimeter implant. Try to drill it 9.5 millimeter. But does not matter. We will not go in the angle. We'll beat the mesial, we'll beat the distal. Very, very rigid. Now, mesial is flush, distal is peeking out less than 0.5 millimeter. Distal is peeking out less than 0.5 millimeter, and it can be there, open. Implant has absolutely no mobility in any direction. Okay, it's hard into the bone. What we are going to do, If you look at the implant, the vertical of the implant is now tilted mesially. This implant is bendable. I can make it go bend it so that it becomes more vertical. When you're bending the implant, I recommend that you bend it before you place the sutures, okay? So that you can look what's going on, and if there is some damage or if there's some problem, you can take some corrections, okay? It's a bending Pramit, I asked you yesterday for my bending tool, BHB. So never mind, I'm going to place any instrument that can hold the top of this implant. Watch at the osteotomy if everything is looking okay. Fantastic. Here, I have bent the vertical with the KOS instrument, okay? The instrument that you use, the placement aid that you use to insert your KOS implant. Idhar इनको दिख रहा है?
ऐसा हम लोग
Yeah.
Hey, Mike, just a question.
Yeah.
Now, if you want to paint it and take it
Yes.
simple,
Yes.
that also you can do it.
We can do that. Or otherwise, yeah, you prep it. Or otherwise, you take out the implant and cut more so that your implant insertion can go more inside. But this situation, I think, was very close. I was just 1.5 millimeter lingual. Okay? Yeah? That would have been a very ideal situation. But now, this implant is not removable for me. So it's okay. We will design the processes around it.
Right.
Now, the better way to check is ask the patient to close and see where the abutment is in relation to the upper. Open. Open. Look. Exactly, my abutment is in the center of the... Can you see? Exactly, it is in the center of the occlusal
Yeah, we can.
platform of the premolar and molar.
Very well. Very well.
You got it?
Yeah.
Now, it does not make sense to bend it lingually because I can give a good occlusion. Patient needs a good bite, yeah?
Yeah.
So it's exactly in between tooth number 5 and 6 and exactly in the center. If my abutment was buckled to the buccal surfaces of the upper molars, I would have definitely done what you said. Prasad, is this clear? Can you see?
Absolutely, we are very nice. Excellent.
Okay, open please. Yeah, finished. Yeah, so Mr. Luthra, thank you for being so proper, take an impression, and it's already been made in the implant. This is a very clear-cut case where you could not have helped this gentleman with any other implant system. BOI is the only solution here. So I think grafting, do some bone that will be fixed. Another case, there's the impression technique on Leone implant, and the third case where a Leone implant has been done and only does PFM cementation. By direct method, we never took impression by using impression post. We prep the abutment directly in the mouth like we do a RC treated tooth or a normal crown and bridge. Standard impression, any standard laboratory can